Hello and welcome everyone. I'm Dr. Komal Lalwani and I welcome you all to today's community of practice session. Today's session is very special as it is by Ms Samantha Riley. The session is on how to make data count in quality improvement in healthcare. So now without waiting for the further ado, I would like to invite Dr. Kedar Soleshwarkar to welcome and introduce our today's guest, Ms. Samantha. Dr. Kedar is the Chief Neonatologist at the Ogre Children's Hospital and Endworld Hospital, Aurangabad. He is the ex-associate professor at GMC Aurangabad. He is a national mentor for Lakshya program by Government of India. He is a national faculty for NRP India, national faculty and member, ex-committee, Development and Supportive Care Foundation for Newborn and Child Health India. He is also a founder member, national coach from Nationwide Quality of Care Network India. He is also a guest editor for BMG Open Quality South Asia Edition and national instructor for FBNC India and national faculty for NEST India. Over to you, sir.
Thank you, Komal, for the generous introduction. And hello to all the QI enthusiasts. Today we are discussing about a very important aspect of quality improvement, that is data. So we are going to learn today how to plot and present data, what is puddling, what is the difference between run charts and SPC, how do we interpret improvement, assurance, how can we understand these terminologies from using the statistical process control chart, what is common cause and special cause variations, how to understand that, and is data only about numbers or something else. Also, we are going to learn how can we use data for quality planning also, and how we are going to narrate the data in our project reports. So friends, today we are going to become SPC champion. This is the first step towards becoming that. And to let us know all the answers to all these questions, we have none other than Samantha Riley from the NHS England to let us know about how to make data count. And I'm glad to introduce Samantha today. It's my pleasure. Samantha has worked for NHS for over 20 years, and she has actually had many roles in improvement in different areas of health sector, including leading a system-wide improvement program in West London, also undertaking a national improvement role with the Modernization Agency, and leading the national rollout of Friends and Family Test and establishing Southeast Coast Quality Observatory. She is very, very passionate about the utilization of data and information to support improvements in patient care, and is a self-confessed information junkie. So she is a very die-hard proponent of statistical process control and how to look at data with SPC and compare it to the use with RAG reports, that is red, amber, green reports. And she has influenced the NHS trust all over the UK, and all the trusts have started using SPC charts in place of the RAG charts. So you can understand the passion behind this and how she has persuaded the entire country and adjoining region to use the SPC chart in understanding improvement, in understanding how to plan quality. And you can obviously understand the benefits of this from a paper which I have posted today in different groups. So you can go through that. So she also has a large collection of SPC books, sunglasses, and impressive shoe collections. So welcome, Samantha. We are really excited to learn from you.
Thank you, Kedar. Lovely to be here with all of you. This was actually a Twitter connection. This is very exciting. So it shows you the power of Twitter. So I'm really pleased to be with you all today. As you've already heard, I'm very passionate about using statistical process control. And I think that we've developed a method which makes it very easy for people to understand. So I'm going to take you through, I suppose, a bit of a summary of how we can use SPC. There's lots of resources that you're going to be able to use freely. So at the end, I want to take you through the different opportunities that there are for you to access for free, That's in terms of training, but also in terms of free resources. So I think we're going to have some time for questions at the end. But I think I'm going to jump into sharing my screen if that's okay. So
Yes,
if you can confirm when it's all working okay,
sure.
that would be fantastic. So let's try.
Yeah, it's very much visible, no problem. Absolutely fine.
Okay. And let's start from the start. So I should be on slideshow, yes?
Yes, ma'am.
Perfect, thank you. So I am Director of Making Data Count. So this is an approach that has been working really successfully across England to change how the NHS uses data. And I work for an organisation called NHS England. So we sit between governments in terms of the Department of Health, and we're there to support organisations in the NHS to improve, but we also are the regulator. So we're there to hold organisations to account for their delivery of services. So there's a bit of a mixture there in terms of what our role is. Now, in the NHS, traditionally, for very many years, we have used a particular type of visualisation that tends to look like this. So I don't know what kind of visualizations you're all used to. I don't know if you see similar things to this. We have lots of targets in the NHS. Again, I don't know if you have lots of targets in your areas of work, but traditionally, these are some examples of how we have looked at data in the NHS. So RAG reports, red, amber, green reports, are the kind of standard method by which people would try and understand how are they doing. So if you look at most reports that clinicians would look at or executives, this is the kind of thing that they would see. And this is probably my least favourite one, because we've got a RAG report and we also have some arrows going on here. So these visualizations make me very sad because they're really unhelpful to us. But this is what most people have been reliant on for a really long time. So why are RAG reports so bad? You might at the moment be thinking, why is Sam saying that these are really bad reports? So this visualization here refers to the waiting times for elective surgery. And we're just going to pull out two specialties here. So here we can see general surgery is all red in the RAG report. It also has a downward arrow at the end here. So that probably gives us a sense that things are not very good. We've got bad performance here, and they're getting worse. Now, if we plot the data over time as a statistical process control chart, if you're not familiar with these charts, don't worry, you will be at the end of this session. This is what we see. So without being experts in SPC, you can see, can't you, that actually there's been some amazing progress made for general surgery. We should be celebrating this improvement. We should be saying well done to the team, rather than telling them off every month because they're not yet meeting the target. So here we've got a good impression or a good example of where we have hidden improvement by using that RAG report. Now let's have a look at rheumatology. It looks the same in the RAG report. So we have got all red and we've got a downward arrow. So what are we going to see if we plot the data over time? And I accept that I'm plotting more data in these SPC charts. But look, we see a totally different picture here. So here we've got deterioration that has been hidden by the red. So it's very easy, isn't it, to misinterpret the messages from data if we are reliant on things like RAG reports. So most hospital boards in England until recently have been using RAG reports, and they've been very misguided in terms of their decision making. They just haven't known any better. And we've done a lot of work over the past few years to really change that. And there's been a real dramatic change in how the NHS uses data. Now, the kinds of comments that I see most commonly to describe data look very much like this. So if you look at a report for a division or a unit or a trust board, these are the kinds of comments that we see throughout the report. So basically telling us that there have been small changes in the data, whether it's an increase or a decrease, but that's really not very helpful to us. Mostly people don't describe to us why there might be changes in patterns in data and also what they're doing about them. It's not very useful to just tell us that a number has changed. Now, why is that not a very helpful thing to do? And this, of course, makes me sad as well. Well, let's think about it. If we've got a number, let's imagine we've got a number 5. What do we know about the second number if we've got a number following that? Well, the options are, it could either be higher, or it could be lower, or it could be the same. So those are the only options, aren't they? So how useful is it to tell us that a number has changed slightly? Now, this might not work with the audience that I've got today, but years ago in England, we used to have a quiz show. This is Bruce Forsyth, and the quiz show used to be about, is the next card that I turn over going to be higher or lower or the same? And basically what I've just shown you in terms of those comments is the same kind of thing. So this was a really fun card show for when I was a child, but we don't want to be playing this kind of game with our data because it's really, really unhelpful. So if we don't want to overreact to a data point going up or down, what do we want to be doing? Well, we need to be gaining an understanding of variation. It's really critically important that we do this. So if we think about my journey to work, and I could get the tube train to work, if I recorded how long it took me to get to work, I might end up with a graph that looked something like this. So we can see that it's not taking exactly the same time for me to get to work. We've got some variation going on here. This is normal variation. This is the expected variation based on the data that I've collected that describes my journey to work. So in SPC language, and this is another SPC chart, this is called common cause variation. So this is expected natural variation. And we do have natural variation in all of our processes, even in healthcare. And sometimes I think we forget about that. So let's imagine that maybe I'm driving to work instead and I encounter a car crash. So let's have a look at a graph that might show my travel to work by car. So here we can see at the end of the graph, the day that there was the car crash, it took considerably longer for me to get to work. So this is unusual variation. And in SPC language, that's called special cause variation. So that's a one-off event, which is unusual. But let's imagine another scenario where I'm driving to work every day, and look, here we've got roadworks. Now, they're not going to have done the roadworks in a day. This is probably going to be something that goes on for an extended period of time. So my journey to work is going to be affected by these roadworks. And we can see on the graph that I've plotted that actually there's been a significant increase in the time that it's taking me to get to work. So again, this is unusual variation, but this is going to be for a sustained period of time. So again, it's special cause variation. And this is the one I think that we really need to watch out for in our data in healthcare. Quite often, if we see the astronomical points, the rule that I've just shown you on the previous example, we might know that there was a very special circumstance that caused this. But quite often, if we're not using SPC charts, we're going to miss this sustained change. So SPC enables us to answer some really important questions. And some of you might already be familiar with run charts. I have to say that we don't even teach people about run charts anymore, because SPC provides us with so much additional knowledge that's really useful to us. And we do now have tools that you can use for free that enable you to create your own charts. So SPC enables us to answer this important question. Are there patterns in the data which identify significance? Is there something changing in my data which is significant that I need to react to? So that's important in my journey to work scenario. But of course, if we're undertaking improvement work, it's going to be really important to understand whether the changes that we're implementing are resulting in improvement. And in England, we tend to use the model for improvement. I don't know if you're familiar with this one, but you probably have something very similar. So what do we want to change? What changes are we going to implement? And how do we know if change has been an improvement? That's where SPC charts are going to give us the answer. So what else do SPC charts demonstrate to us? Well, they demonstrate the extent of natural variation. So if we look again at the chart that shows my travel to work by tube train, what do we learn from the charts? Well, we can see this dotted line at the top is at around 55 minutes. The line at the bottom is at around 24 minutes. These dotted lines are based on the data that's plotted within it, and they describe to us the range of natural variation that we can expect. So if we look at this chart, we can understand that there isn't anything changing significantly in my data set, and I can expect my journey to work to vary between 24 and 55 minutes. So that's another really useful thing about SPC charts. Now, I've been teaching about statistical process control intensively for the last 5 years or so. And people sometimes ask me, is SPC a new thing? Well, it's absolutely not a new thing. It's actually been around for 99 years. So next year it's going to have its 100th birthday. This started in the manufacturing industry to try and measure defects in things that were being produced on the production line. But these are highly applicable to healthcare, the approaches of SPC. So here's a couple of examples of papers that demonstrate why those RAG reports are really bad, but there are hundreds of papers that relate to why this is very beneficial if we apply this approach to clinical data. So we've got a strong evidence base that if we use SPC, we make better decisions. And this paper may be the paper that Kedar was referencing earlier. So this is something that I had published in BMJ Leader a couple of years ago that looks at the impact of how our trust boards in England, what's been the impact of them changing to SPC, how has it changed their decision making. So this is an open access paper, so you might want to have a read about that at the end. And I accept that this is about how boards have changed how they use data, but our experience of training 25,000 people now is that actually whatever level you're making this change, it's going to really change how you use your data. Now, in England, over the past few years, there have been a number of investigations into poor maternity care. And this is the report that I don't know if you're aware of, but it might be worth you having a read of this one. So this was an investigation into some very poor maternity care at a trust down in Kent in the south of England. So there were lots of findings within this report. The thing that I was pleased to see in terms of a recommendation, a key recommendation, is that there is now an expectation that organisations in England use statistical process control to present their data and to understand what's happening. So how are they understanding the different types of variation that they're seeing? How are they reacting to that? There is a requirement now for people to start to use SPC charts and also funnel plot charts that I'm not going to cover today because we haven't got time. So this is a really good move in terms of the recognition that SPC really does add value to us. So let's look at the anatomy of a chart. They are simple charts, they're nothing to be scared of, and I think sometimes, at least in England, we have overcomplicated these charts. I should say as well that there are lots of different types of SPC charts. The primary chart that we teach in the Making Data Count approach is called the XMR chart. And the great thing about the XMR chart is that that is applicable to virtually any type of data that we've got. So it's the kind of jack of all trades, it's the Swiss Army knife. We can use this for virtually all of our data. So the anatomy of a chart, we've got the data plotted in the middle of the chart, like we've seen in the examples that I've shown you already. And then we have 3 lines on the chart. We've got the mean line, and we've got these dotted lines that are called process limits. Now, I'm not going to go into the maths of how the process limits are calculated, because if you join some of our training sessions, you're going to learn about that. What I will say is that the really important thing to remember is that those process limits are going to tell us what's the range of expected variation. So we can expect around 99% of the data points to fall between those process limits. Now, we do need a certain number of data points to create one of these charts to make it robust. If we've got 15 or more data points, we've got enough data. Then in England, this really isn't a problem for us because people are collecting a huge amount of data. If you've got less data than this, that's when we would recommend a run chart. So we've got rules that are applied to the data, and these are the 4 rules that we are recommending in the Making Data Count approach. If one of these rules is triggered, it's telling us we've got an unusual pattern, a pattern that's unlikely to have occurred randomly. And the term for that is special cause variation. So we've got a single point outside the process limits. Of course, we now know that's unusual, don't we? Because 99% of the data points are going to fall within the dotted lines. And again, we may already know what caused that. That might be a very special circumstance that we already know about. 2 out of 3 points close to a process limit, that's a good early warning alert. Then we've got a shift of points above or below the mean, and we'd be looking for a shift of 6 or 7 points there to show significance. That's the rule that we see most commonly in the NHS in England. And then we've got a run of points in ascending or descending order. So if a rule is triggered, it's telling us there's something unusual. Now, one of the things that we've learned is really important is we don't want you to have to remember these rules in your head and count the dots. We need this special cause variation to be highlighted for you automatically. So we've got a colour convention that means if you see orange dots, it means we've got a concerning pattern in the data. And if we've got blue dots, we've got improvement in the data. Now, if you are colourblind, you can see the difference between those colours, and you can't see the difference between those red and green colours that we've been using for quite a long time. So on these charts, all you need to look out for is blue dots means improvement and orange dots means deterioration. And all of our tools do this colour convention for you automatically. So if we've got a rule triggered, if we've got special cause variation, we need to go and investigate. We need to go and ask some questions. But SPC can also help us where we've got targets. And again, I don't know if you have imposed targets in the areas that you work. We have lots of imposed targets. Targets can sometimes really drive improvement. And one of our training modules now talks about how we can set a target to drive improvement. But where we have got a target, SPC can really help us. So if we look at this chart, we've got a target to be achieved of 40 or greater. What do we know from looking at the SPC chart? Well, we can see that we're not going to achieve this target. So we haven't got a hope of achieving this target. If we want to achieve it, we need to do some redesign work using something like the model for improvement. In this situation, it's the opposite. So here we are always going to be achieving the target. We've got a capable system. So here we might want to celebrate. We might want to learn from what's going on here. We might want to think about changing the target. And in this last example, here we've got the target line very close to the mean line. This basically means that we're going to flip-flop between achieving the target and failing the target. That's going to happen at random. So it's going to be pretty much a 50-50 chance here. So I think in this situation, we would also need to do some redesign work. So in terms of maximising the impact of the charts, we've got the colour convention that I've mentioned to you already. So orange for concern and blue for improvement. Grey dots just means there's natural variation that we shouldn't overreact to. How do we avoid having lots and lots and lots of charts? Because that's probably not helpful. We've come up with the idea of using summary icons to summarise the important messages from the data. So the variation icon tells us what's happening to variation. So very simply, if you see an orange icon, it means it's getting worse. A blue icon, it's getting better. The grey icon, it's not changing. And then if we have got a target, the blue P is going to assure us that we can consistently pass the targets. The orange F, we're going to consistently fail it. And then the question mark is where we're going to hit and miss the target at random. So we need to have SPC charts, but what we also need is to have a good description, an accurate description of what the data is telling us. And we provide a specific training module on how to write good narrative. So we don't like RAG reports. We also don't like horrible visualizations of data. And this is a horrible, but again, a very common visualization of data in England. We call them spaghetti charts. We've got a different coloured line for a different trust here, a different hospital trust. It's very difficult to understand what's going on here. You need to untangle the spaghetti. We can't tell where we're seeing significance. So what would we do in this situation? We'd want to untangle the spaghetti. We'd want to plot the data as SPC charts separately. And immediately now we can see very clearly where we are seeing different types of variation. So site 5 is showing significant improvement. And this is looking at percentage smoking at booking. We can see a couple of sites where we haven't got any statistical change in the data. And then we've got 3 sites here where we are seeing deterioration in the data. So it's much easier now, isn't it, to see what's going on. We could, of course, have an icon summary rather than having all of the charts, and it takes a little while to get used to these icons. So here's the icon summary for the data that we've just seen. So we've got 3 areas here where we're going to be concerned and need to go and do an investigation. But then we can see that site 5 is showing improvement. So we want to celebrate that improvement. And we might want to go and ask them what they're doing so that we could learn about that improvement and look at how we could spread that elsewhere. Here's an example from another trust that we've worked with, the trust in the middle part of England. So here we can see the percentage completed VTE assessment risk at antenatal booking. So what type of variation are we seeing? Well, we can see orange dots at the end of this chart. So that's definitely of concern. Will we achieve this target? So the target is the red dotted line on this chart. That's at 95%. Well, we are going to achieve this target. So some people might want to be celebrating. But of course, we know we've got those orange dots at the end of the chart telling us that there has been a significant change in our data for the worse that we need to go and investigate. And if we think about if this was presented in a RAG report, and this organisation did use RAG reporting about 2 years ago, then they would have missed this improvement because it would have shown that the performance was all green because they were still achieving the target, but we know that there's a statistical deterioration that should be reacted to. Now, thinking about some of the maternity measures, we do need to think about how we deal with some of the data. And I already mentioned to Kedar that maybe if you go on some of our training and you have some specific questions related to maternity, then it might be a good idea for us to run a session later in the year where we can answer some of those more specific questions. But here's a good example of where we need to take a slightly different approach and need to use a slightly different chart. So this is data looking at stillbirths, and we can see here that there is quite limited variation in terms of the number of stillbirths that are plotted on this chart. So we've only got the options of there being 0, 1 or 2. This is rare event data. Is it that helpful to plot the data like this? Not particularly. This particular trust was concerned about the fact that they'd had 2 stillbirths on one day. And I suppose the question here is that clearly every stillbirth is awful and it needs to be investigated, but was there something different here that had led to those 2 stillbirths on one day? Now, how we need to use this data is we need to apply a different approach. We need to use something like a G chart. And as I've said, we can run a separate session to look at some of this more complicated stuff. But what we're looking at with a G chart is looking at the number of events that were positive in between those negative events. So a G chart would look at the number of living births in between us having a stillbirth. The colour convention is the same here. So here we can see that actually we're seeing expected variation here. We can see the mean line is at 200 here. We could expect to see 200 live births in between seeing a stillbirth. And what we can learn is that although earlier in the year they did have a period of concern that should have been investigated, actually that example where they had stillbirths of 2 on one day was actually not of statistical significance. So as I said, particularly for maternity data and for rare events data, we do need to use a different approach. The good news is that we do provide a range of training modules that you can work through that go through some of this more complicated area in more detail. Now, my colleague Karen, who you may meet in a future session, she's very involved in some of the national work now around maternity, and this is on the back of that report that I referenced about the East Kent maternity failings. So Karen has worked with a number of trusts to come up with a best practice maternity dashboard. And I'm sure that this is something that we'd be able to share with you as it grows over time. But we can see here that we've got a range of measures here that have been identified by clinicians in terms of being really important to monitor. So we have some contextual measures around the number of births. We have some information about staffing fill rates. And then we have those clinical measures that are important, including some rare events charts that are over to the right-hand side there. So I'm very happy for us to come back to you in a few months' time, maybe, once you're a bit more familiar, to talk about this in a bit more detail. So we can use SPC to evidence improvements. Just to say, we're going to use the model for improvement if we're going to do something like that. And hopefully we're going to end up with an SPC chart that looks like this, where we've annotated what we've done in terms of changes, and we've seen a step change in the data. And just to say, if we are going to be doing any improvement work, I'm sure that you know this already, it is really important to take a baseline before you make any changes, because if we don't know what the situation was before you implemented any changes, we're not going to know if they worked or not. So this is a little made-up scenario that I used when I presented at a conference for the Society of Geriatrics earlier in the year. So this is a made-up example. This is looking at comprehensive geriatric assessment. So let's imagine I've got 2 weeks of data. So look what impressive improvement I've got here. I've moved from 56.87 to 80.89. That is absolutely amazing improvement, isn't it? I've proven that with my data. Let's add a couple more data points. Well, it's a little bit of a shame, isn't it, to see that those 2 additional months now aren't as high as the data for the 8th of May. But actually, I'm not going to really worry about that, because if you look at the difference between the first and last data point, we've got a 10.84% improvement, which is incredibly impressive. I'm sure that you would agree with this. So we're going to have a little celebration, because that is wonderful. But let's imagine, and you'll now know from looking at this graph, won't you? The question, are assessments changing? Well, the answer is absolutely no. And what if those 4 data points that I've just celebrated as improvement for those 4 data points at the end there, that would have been premature celebration. That wasn't true, was it? We hadn't seen improvement in the data. That's why we need to be using SPC if we are implementing change. Let's imagine now, let's extend the data set. I've made some interventions now here. The medical director made this a priority. Then my colleague Tony asked staff to complete assessments. And then we had an article on the Trust intranet. Has my improvement plan worked? Well, actually, you can see the process limits are now wider. So actually, I've extended the range of variation, which is not what we want to do. So the answer to this is absolutely no. The SPC chart shows us that. And let's move forward time now. So now what have I done? I've run a big improvement event. And actually now we've got improvement pathway meetings that have commenced. So the question, has this now been successful? Well, we can see that now there has been success in the data. We have now got some narrower process limits, and we've got blue dots at the end of the chart. So that is, of course, to be celebrated. That's what we are aiming for. So here's just the last few examples, real examples from trusts in England. This is looking at the percentage mortality rate for suspicion of sepsis admissions. Look at those blue dots that have extended over a long period of time. Very significant improvement. In fact, that was a 1% reduction in mortality rates. So that was a brilliant example of improvements. These charts relate to a trust that has 2 A&E departments, emergency departments, and these measures relate to different elements of A&E care. Doesn't really matter what the measures are. You can see that every chart here has got blue dots. So a big celebration to take place there. It's very motivational for people to be able to see very easily that their improvement work has worked. And they only have to remember to keep an eye out for the blue dots. If they haven't got the blue dots, they haven't got the improvement. And here's an example from Twitter. So this lady, Ree Sharp, she'd led a falls collaborative. So the trust wanted to reduce the number of falls. They'd done lots of work, but they didn't know if it had worked. And that was the ultimate question. So we can see a happy lady here because she has plotted her data using one of our tools. and she's got blue dots that demonstrate that there is now improvement in the data that is true improvement. So that's a good few examples, hopefully, to demonstrate that SPC charts are actually easy to produce, they're easy to understand, and they're really important in terms of evidencing that improvement. I just want to finish now with a few minutes just to tell you what support is available, and all of this is available to you for free. So the most important thing for you to go away and do, I think, once you get the slides, is to join our Futures platform. And I'm sure we can put this in the chat while we've got this session still live. So we've now got over 8,500 members of this site. And this is our key site for sharing advertising events, providing you with tools. Now, what you are all going to need to do if you want to join this space is you're going to need to click the box here that says contact the workspace manager. So anybody can join this site, but because you don't work for the National Health Service, you won't be able to do that automatically. So if you just drop us a little line, then we will provide you with access to the site, no problem at all. We've got a range of folders that you might want to go away and have a look at. We've got a whole range of SPC tools. I don't know if Kedar has used any of these yet. I know that he's attended all of our training and actually been watching some of the recordings to refresh his memory. So this is a tool that's based in Excel. It's very easy to use, and you can basically just paste in your data, input your data, and then you'll end up with an SPC chart that does the color convention for you. We can see the icons on the chart. We can put interventions on the charts here. It's very easy to use. This was designed for clinicians to use themselves. We provide a lot of training, so all of these are hour-long sessions, and again, they're all free for you to access. We do record all of these sessions and put them on the Futures site and provide all of the slides. Now, you don't have to do all of these, and you might want to pick the ones that you do. There is a logical order to them. We do ask that you do the step 1 introduction at the top there before you do any of the others. But there is a logical structure to go through here. So step 2 looks at using our tools. Step 3 looks at how to write narrative, which drives improvements. Step 4, we go into more technical things like the rare events example I've talked to you about. We also run a module on how do you benchmark effectively. And then if you're not very familiar with improvement techniques, I'm sure that you all are, so you might want to miss out on step 6 that looks at improvement techniques. Step 7 looks at triangulating data. Step 8 is data-driven conversations. And then step 9 is about how do we use the qualitative data that we might have. That's a very different technique. And then the last step has been targets and trajectories. We basically run each of these, so 1 a week, and we're starting again in September. So you might want to watch the recordings, or you might want to sign up for those sessions starting again in September. We have interactive PDFs that you can access from the NHS England website, again, very freely. They're very easy to use. We've got embedded videos, they're very practical, and we've got little scenarios for people to work through. There's lots of resources and support available. There's lots of peer support that's provided on the Futures site by those 8,500 people that are members. You can also book a slot with one of my team if you've got a specific problem. I've already referenced the fact that we've got SPC chart tools in Excel. We've got a range of those, but also if any of you use Power BI or are experts on SQL, we have SQL scripts, we have Power BI tools. The NHS R community has developed a solution in R, and also the Python community, and that is all on the Futures site, and again, all freely available. So I'm hoping that I have persuaded you that it's a good idea to become an SPC champion. So I have an invisible SPC cloak on. I'm a champion. I know that Kedar has got a cloak on in addition because he's a champion as well. It really is making a difference to lots and lots of patients in the NHS. I'm sure it will do for your patients. So I'm going to stop there and say thank you. And that's my email address. I do use Twitter only for making data count related things. And if you do take a photograph of that QR code, that's going to take you to a site that gives you links to all of the things that you're going to want to reference. like the future site, like the tools. So I'll just leave that up there just for a little sec so you can take a photo. And of course you'll get the slides after this, but I'm gonna stop talking now and hand back to see if there are any questions.
Thank you, Samantha. Thank you for a very lucid presentation on how to make data count and how to use SPC charts and understand improvement, variations, and so many things to learn. We understand that in short time, it's not possible to cover all the 10 steps which you have described here. So, but we hope that in near future we'll have more lectures pertaining to specific topics regarding making data count.
And Kedar, you said that you'd found it useful, didn't you, joining the step training?
Yeah. Well, when I started using this SPC chart in place of run charts, then I came to understand actually what is improvement and understanding variations and all those things. And when we are actually plotting the data and putting it on our visual management board during huddles, explaining the stakeholders regarding what is happening with the current situation with this particular indicator, that is really helping us to motivate all the stakeholders and understand what is happening. So one of the actually use of the SPC chart is even motivating the staff and celebrating it when you see those orange dots. So that was actually very good use of charts. So Soumitra wants to ask some questions. Soumitra, you can unmute yourself and ask your question. Komal, can you unmute Dr. Soumitra Haldar?
So we have allowed him. So Dr. Samantha, you can unmute yourself.
Soumitra, you can unmute yourself and ask your question.
So till Dr. Samantha unmute, there is one more question in the Q&A session, sir.
Yeah, I'll just read it. So Dr. Amol Joshi says, thank you, Samantha, for your presentations. These resources are promising. Is there any way to plot SPC charts with the different time intervals?
So maybe the question is daily or weekly or monthly or individual patients maybe.
Amol, can you specify it?
Dr. Amol, you can directly ask your question.
Yes, actually, thank you. The query is, as the improvement progresses, initially we are plotting the data depending on the QI project, maybe daily. Then gradually we reduce the number of data points, like plotting weekly and then plotting monthly. So if you want to represent all the data points on the same chart, is it possible by the tools given or the resources displayed in this future NHS website?
Okay, so that's a good question, and we definitely would encourage you to measure more frequently when you start to do improvement work. So that's great that you've mentioned that. We haven't actually got a tool that will enable you to change the time within the same charts. I think what we'd encourage is maybe to start off using that single chart tool that I've shown you there with daily data. And then maybe you could start to plot another chart using weekly data and then maybe monthly data. We do have a dashboard option that enables you to create a whole dashboard of different charts. So that would be something that you could look at in terms of creating a dashboard that had a whole range of different measures included within it. And if there's something that you would want specifically, then we definitely look at whether we could create that for you as well. Karen's the very clever lady in my team that creates all of the tools. So we're always looking to expand what our offerings are. So maybe have a play at what we've got and then get in touch if you've got some ideas about something else that's useful.
Yes. Thank you so much. Get back to you. I'll get back to you. Thank you.
Dr. Bhaskar, can you ask your question?
Yeah, good evening. It was very informative session. Actually, I am from a lab medicine. I work for a government medical college as an associate professor, and I'm an NAPL and NAPHS. So we are more into the digging the data of lab data analysis. So when I read that slide about SPC chart about the sticking to the baseline when you set the different targets by violating the baseline, then there will be a lot of issue. So like in lab data, when we follow the waistguard rules, like 1-2S, 2-2S, 1-3S, R4 and R10. So so we define these all data in a different way, that lab errors, like it's a random error or a systemic error. So likewise, what you have mentioned in SPC chart, that certain data are falling on the same side of the continuously on the mean, on the one same side of the mean continuously. So then there will be some systemic error, like when we see that continuously 10 data or continuously 4 data are on the similar side of the mean, then there will be always chances of some systemic error which has been ignored or bias. So it's like what in waistguard rules we tell that it's a R4S or R10, rule R10, systemic error. So is this correlate well with the SPC chart evolution, or we can incorporate such kind of error monograph for hospital data also, like for a infant mortality rate, maternal mortality rate, vaccination ratio, then adherence to safe clinical practice, hand hygiene.
Thank you. So I think this might be a good one that we might want to take offline. But to say if we're seeing patterns in the data that are happening over an extended period of time, then we would want to do something called recalculate the process limits. And that's something that we cover in one of our more advanced steps. My experience, we have got people that work in labs that would use this type of approach. They found it beneficial. So I think that this can apply to the areas that you are referencing, in terms of all of the areas that you've referenced. But maybe go away and have a look at what we've got and have a little bit of a play with the data. And then if you have questions, then you can come back and maybe book one of those individual slots with us.
Okay, thank you, ma'am. Thank you very much.
Thank you, Dr. Bhaskar. Dr. Samitra, would you like to ask your questions if you are available? I think he's not. So I invite Dr. Praveen Venkatgiri for his words. Dr. Praveen.
Hey, thanks, Kedar. Thanks, Samantha, for an excellent lecture. So I think I just need to start learning. I'm not used to using the data like this. So I'll take download from Kedar. And as you said, if more queries are there, probably we'll connect back to you. But fantastic. Thank you so much for that.
Thank you. So Kedar, if you had a way of collecting maybe any questions that people have, I don't know if you have the ability to do that. Then
Sure, yeah. We can. The office will collect and send you the queries. Yeah, definitely. Yeah. So,
and if you have more technical queries, then I will bring Karen along, because I'm not a statistician and Karen is a statistician. And I think some of these questions are maybe more statistically complex.
Yeah, sure. So I invite Dr. Pangal sir for his comments.
Good evening, everyone. I joined little late because of my duty, but definitely, as Dr. Praveen said, I'm a clinician and not very much used to data analysis and data presentation. But whatever I heard, it was a new learning for me, and maybe we will also start using these charts for our data presentation in future. Thank you very much.
Thank you, sir.
We'd love to see any charts that you produce.
Sure, sure. Because since last 3 years, a lot of quality improvement projects we have started doing in the department. I am OBGYN and to all many postgraduate students, I have given small projects, quality improvement projects. So they will be coming up with the data, and we will definitely use these new methods of data presentation in their data analysis and data final thesis. Thank you very much.
Thank you, sir. Now, if Dr. Vikram is there online, I invite Dr. Vikram, our president, for his talks on today's presentation.
Thank you so much, Kedar. In fact, it was phenomenal to listen to Ms. Samantha. In fact, quite enlightening for all of us, and considering that this is one of the next steps which we are looking forward in NQOCN, moving beyond the usual run charts. And we've been, deliberating internally that we've really got stuck to this, and we need to move on. And as we embark on more complex problems, like later this week, we are embarking on an adult intensive care settings where we are rolling out quality improvement interventions in South India. I think it would be very, helpful if our teams can seek some more mentoring support from you of making data count and also gaining access. I was trying to log into the Future NHS website and create an account at this point of time as we were talking, but it is probably not registering the email IDs. It would probably require a direct, invite from one of you. So I request the NQOCN office to please facilitate, get in contact with you and see how our members can directly, become members of the Future NHS group also. And as an organization, NQOCN would be keen to partner with the Future NHS collaborative group, and also look forward to working together in this area of work. Thank you so much, Kedar, and congratulations once again for an excellent session.
Thank you, Dr. Vikram. I think Dr. Prabha has got some question. Prabha, can you unmute yourself?
Good evening, everyone. My question is this anything like that for a short-term studies, like for 1 year studies or 6 month studies, we should use run chart, and for long-term studies like for 2 to 3 years, we should use SPCs, or we can use SPC for short-term studies also?
Yes, so you can use SPC charts, and we would encourage the use of SPC charts over run charts as long as you have enough data points. So if you've got those 15 data points, and then use an SPC chart, and the tools that I referenced, they will plot a run chart if there isn't enough data. And then when you do have enough data, it will automatically add those additional lines. And of course, the benefit of SPC over a run chart is it's going to show you automatically the significant patterns in the data. The limits are going to show you the expected range of the data. And so 5 years ago, I think that we did teach people about run charts and SPC charts. And our experience actually was run charts in some ways were more complicated because you had to keep the rules in your head. And now we've got those free tools that people can use, including clinicians. So we would encourage use of SPC charts as long as you've got those 15 data points or more.
Okay, thank you so much.
Is there any other question, Komal?
No, sir.
Then I hand over to you for further deliberations.
Yeah. So thank you so much, Ms. Samantha, for the wonderful session. Now, I request all the participants to please fill our feedback form for the session and the certificate of participation if you want to avail. The link is there in the chat section. You can directly click on the link and fill a short form for both the feedback and the certificates. Any other participant or panelist would like to share your inputs? Participants can just raise your hand. We will allow you to unmute yourself.
Yeah, Dr. Bhaskar here. So it was a very excellent session on the data analysis used for hospital setups. So being a NABL assessor, usually I assess a lot of data for quality in lab parameters. So I am also looking after such a informative sessions, and these lab data and lab data evaluation methods like Visgar rules, what we follow for QC, that can be incorporated in a different SPC charts to get a good output in a collaborative manner. Like for a lab errors, we use different Visgar rules, different QC charts. So similarly, it can be used for a lot of hospital incidences like hand hygiene and adherence to vaccination protocols, ICU safe practice, and all those. So I'm looking forward to such collaborative data interface where hospital and lab data work together in a collaborative manner to give maximum output. So we can have a better understanding and a simpler understanding of our own data. So looking forward to such informative session, and I am very much thankful to NQOCN for organizing such an informative session. Thank you very much.
Thank you so much, Dr. Bhaskar. I would like to call Dr. Taslima for sharing her comments.
Hi, everyone. Thank you so much, Ms. Samantha. I joined late, but it was, what I heard was really wonderful. But actually, I took this opportunity to thank NQOCN, basically, to giving such a platform and, introducing really good resources for us to utilize. So I would like to just thank the president for giving this opportunity. And I'll definitely be in contact with you. I'm actually from the Maldives, not from India, and working as the Commissioner for Quality Assurance with a huge mandate. I have worked with the NQOCN, and they have been really, really helpful to us. They have gone beyond their, I would say, call of duty to train people in the Maldives as well. So I would definitely be in contact with you, because this is an area that is really required in the Maldives. Especially data is important, because then they know where they're going. Otherwise, they don't know where they were and where they're going and what can they do to improve. So data speaks in a totally different language. It's a beautiful language when, giving self-credit, giving credit to the people who are working, and also doing, much, much more. So we'll be in contact, and thank you so much, Dr. Vikram, and thank you, NQOCN.
Thank you so much, Taslima ma'am. We look forward to seeing more of interactions between the various international partners on this Communities of Practice platform. Thank you for coming and gracing the occasion.
Thank you so much, ma'am. So now I would like to hand over to Dr. Kedar to conclude this session.
Thank you very much, Dr. Samantha, for enlightening us on how to make data count. It was a wonderful discussion, and also I'm thankful to all the participants for their active participation. And I hope that we start using the statistical process control chart tool and plot the data using the SPC and understand the variations and improvements. So that was a wonderful and eye-opener, I can say, for all of us in quality improvement in the South Asia region. So I'm also thankful to NQOCN office for arranging this webinar in a very short notice. And what I gathered from the chat is it's Samantha's birthday today. Is it that?
Yes.
Wish you happy birthday.
Thank you.
All of us.
Thank you very much. And thanks for inviting me. It's been wonderful.
Yeah, that's wonderful. So thank you, and the Secretary NQOCN, Dr. Praveen, and all the office bearers and delegates. Thank you for attending it. And definitely, if there are any queries or if they want more to learn about it and get some SPC surgeries done, then we'll definitely contact you. And hopefully in near future, we'll have you again for a specialized talk. Thank you very much.
Thank you.
Bye. Good night.
Bye.
Thank you so much, everyone, for joining.